Okay, let's unpack this. Today, we're taking a deep dive into one of those areas that's, well, famously challenging but really crucial for any orthopedic resident prepping for exams: distal tibia and pilon fractures.
Yeah, definitely challenging.
And this isn't just about, ticking a box on an exam. It's about getting your head around a complex injury you'll definitely see.
Absolutely.
So our mission here is to cut through some of that complexity, pull out the core insights, the things you really need to know. And just to be clear up front, everything we're digging into today is based on the fantastic ortho-made simple notes. You can find them at mokyingren.sg.
Great resource.
They were put together by Dr. Mok Ying Ren. He's a sports surgeon over at National University Hospital in Singapore, finished his FRCS back in 2022. Really comprehensive stuff.
They really are. And, understanding these fractures properly, it's more than just theory. It's about that diagnostic precision, the planning. That's what leads to better outcomes for patients. These are serious injuries.
High energy, right?
Exactly. High energy, often devastating. So getting the nuances right is key. For exams, yes, but really, for every patient with one of these fractures, it tests everything: your anatomy knowledge, your judgment, your surgical skill.
Okay, so let's start right at the beginning then. You see one of these come in. Before you get bogged down in the details, what's the first thing you're looking for? Maybe that initial clue on the x-ray that says, okay, pilon fracture. And how does the mechanism, how the injury actually happened, show up?
That's a great starting point because the mechanism really tells you a lot. You're usually looking at a big axial load, right? But there's often a varus or valgus force mixed in.
Right.
And the fibula, well, the fibula often gives you a big clue right away. See a simple fibula fracture, maybe oblique. That usually means the limb failed in varus, the fibula just sort of bent and snapped.
Okay.
But if that fibula is shattered, really comminuted, that points towards a valgus failure mechanism. The fibula got crushed, essentially.
Yeah.
So the key thing is the fibula isn't just along for the ride.
Yeah.
Its fracture pattern reflects those forces that smashed the tibia plafond.
That's really interesting. So knowing varus or valgus from the fibula, does that help you predict anything else? Like which bits of the tibia are likely to be involved? Because they're not just random pieces, are they?
No, absolutely not. That's what's fascinating. Despite the different ways these can happen, you tend to see the same key fragments involved again and again, almost like a signature pattern.
Okay.
There are four main ones you really need to know as a resident. They pretty much dictate how you'll approach the surgery.
Right.
First, there's the Volkmann's fragment. That's the posterolateral one, linked to the PITFL, the posterior tib-fib ligament. The topless paper, which is really essential reading on this, suggests this fragment is almost always there. It's constant. And it's crucial, because if you don't nail this piece down, getting the rest of the joint stable is really tough. It's often your foundation.
The cornerstone, kind of?
Exactly. Then you've got the Chaput fragment. That's anterolateral, associated with the AITFL, also key for the front of the joint.
Okay.
Then you often see a medial malleolus fragment tied in with the deltoid ligament, and of course the infamous die punch fragment.
A die punch.
That central impacted piece where the talus has literally just punched into the plafond. So recognizing these, especially Volkmann's and Chaput, gives you an immediate idea of where the main instability is. It's your first roadmap, even before the CT.
That makes a lot of sense. Having that roadmap early must be a huge advantage. But given how complex these are, I guess classifications become really important for talking about them, planning.
Oh, absolutely essential for communication, for planning, definitely for exams, too. The Ruwaidi-Allgauer classification is kind of the classic starting point.
Right, the type 1, 2, 3.
Yeah, exactly. Type 1, non-displaced. Type 2, simple but displaced. Type 3, comminuted, the really smashed ones. It gives you a quick snapshot of severity, a basic how bad is it.
But maybe not detailed enough for planning?
Well, that's where the AO classification comes in. Specifically for distal tibia, that's bone 4, part 3, so 4.3 fractures. This divides them into A, B, and C.
A, B, C,
Yeah.
articular involvement, right?
Precisely. A is extra-articular, outside the joint. B is partial articular, some joint involvement, but part of the joint surface is still connected to the shaft. C is complete articular. The joint surface is totally separated from the shaft.
Okay.
The AO really maps out your surgical challenge. It tells you how much of the joint is involved.
And then there's topless, the CT one.
Yes, exactly.
Yeah.
The topless CT scan classification adds another layer. It looks beyond just comminution or articular involvement and categorizes based on the main fracture lines. Are they predominantly in the coronal plane or the sagittal plane? these
Okay.
fracture families.
Coronal or sagittal families.
Right. This gives you much more granular detail about how the fragments are oriented, which is super helpful for choosing your surgical approach, figuring out which bits to tackle first. Like a dominant coronal plane fracture might push you towards a posterior approach.
Okay, so here's where it gets really interesting then. You've got your classification.
Uh-huh.
How does that directly guide what you do right away in that acute phase before definitive surgery?
Right. The acute management. This is where that mantra, span, scan, plan, is just gold, especially for these high energy ones.
Span, scan, plans.
Okay.
Okay.
First, span, ATLS, stabilize the patient. Crucially, check for compartment syndrome, always high on the list. Then get an external fixator on, spanning the ankle joint.
Why span?
It provides stability, protects those very vulnerable soft tissues, helps control swelling, and gets the limb roughly out to length and aligned. Buys you time.
Makes sense. Then scan.
Scan. Once things settle a bit, patient's stable, you get a good quality CT scan. This is non-negotiable. It shows you everything the X-ray misses, the hidden comminution, the exact articular displacement, all those key fragments. It lets you classify accurately. And only then, after you've spanned and scanned properly, can you really plan the definitive surgery. The staged approach, letting the soft tissues calm down, getting the full picture, it dramatically cuts down complications. I remember a case, looked okay on X-ray, but the CT showed this massive die punch we almost missed. The scan part saved us there. Rushing is risky.
Patience and good imaging definitely sounds key. And just a quick reminder for you listening, everything we're diving into today is based on those excellent ortho-made simple notes from mokyingren.sg. So we span, scan, planned. Now, moving towards definitive management, let's talk about something that always comes up. Fibula fixation. Big controversy, right? Is it needed? When do you fix it?
Ah, yes, the fibula debate. It really highlights how things evolve in orthopedics. The traditional Ruedi Allgauer teaching was fix the fibula first, restore its length, its rotation, and somehow that helps reduce the tibia.
That was the thinking, yeah.
But recent evidence has really stirred the pot. There's a key study, Carullo et al., from JOT in 2015. They looked back at over 100 patients, 3 groups, no fibula fracture, fibula fixed, and fibula not fixed.
And what did they find?
Well, pretty compelling stuff. They found no significant difference in the final alignment, whether the fibula was fixed or not. But, and this is the crucial bit, the group with the fixed fibula had significantly more complications, mostly needing the hardware taken out later.
Wow, so more surgery, same alignment.
Essentially, yes. Their conclusion was pretty clear. Routine fibula fixation often isn't necessary and might just add complications. It definitely challenged the old dogma.
Okay, so that's powerful evidence. But in practice, how do you decide? I mean, other times you do fix it?
It's nuanced. Personally, I rarely make the final decision on definitive fibula fixation right at the start when putting on the X-fix. You want to keep your options open. The decision comes later, after the CT, usually during the definitive tibial surgery itself.
So you don't lock yourself in early?
Exactly, because fixing it early means you can't choose not to fix it later, which might be better based on that Carullo study. However...
There's always a however.
Right. There is a definite benefit to fixing the fibula provisionally sometimes during the X-fix application. If the tibia is really shortened and collapsed, plating the fibula quickly can really help you pull things out to length. It aids distraction.
So it helps with the initial reduction?
Yeah, it can make applying the X-fix and getting initial length much easier. So you might put a plate on temporarily for length during the X-fix stage, but then decide during the main surgery whether that plate needs to stay definitively based on the tibial reduction and overall stability. It depends heavily on the specific fracture pattern.
That makes sense. It's about using it as a tool when needed, not just doing it routinely. Okay, so moving past the fibula, what are the main options for definitive treatment? And if you're going for ORF, open reduction internal fixation, what's the step-by-step game plan?
So for definitive management, you've got a few main routes. ORIF is common, especially if you can get a good reduction of the joint surface. The big advantage is allowing early range of motion.
Which is good for the cartilage.
Hugely important. But if the soft tissues are really bad, or the patient has severe vascular disease, bad diabetes, maybe definitive ring fixation like an Ilizarov frame is safer, less soft tissue stripping.
Right.
And for really severe comminution or maybe an older patient with low demands, primary ankle fusion is sometimes the best bet. Sacrifices motion but gives reliable pain relief and stability.
And you mentioned distractors.
Yeah, adjuncts like the X-fix itself or even a femoral distractor intraoperatively can be really helpful. They pull the main fragments apart using ligamentotaxes, kind of stretches things out, which can indirectly reduce some pieces and just makes the direct reduction easier, like opening up that collapse puzzle you mentioned.
Okay, so let's say you're doing an OREF.
Hmm.
Walk us through those Ruedi and Allgauer steps. What are the key goals?
It's a logical sequence, really. Step 1. Restore fibula length and rotation. If it's a simple fracture you can fix anatomically, you often do that first. If it's smashed, maybe you bridge plate it later.
And it's the right length.
Key signs are the dime sign on the mortise view, that smooth curve from the fibula tip to the talus, and checking the talocrural angle, which should be around 80 degrees. And don't forget rotation. Easy mistake to make. Getting the fibula right sets the stage for the tibia.
Okay, fibula first sometimes.
Yeah.
What's next?
Step 2, the absolute crux. Anatomic reduction of the articular surface. This is where you earn your money. Usually involves an anteromedial approach. You open the book, often by hinging on the chaput fragment to get direct visualization of the joint.
See the damage directly.
Exactly. Then you meticulously elevate those depressed fragments, that die punch piece, reducing them back up to the level of the intact cartilage, often using the stable posterior fragment, if you fixed it first, as your reference. It's like assembling a mosaic under pressure.
Sounds intense. Then what?
Step 3. Address the gap underneath. Once you've lifted the joint surface, there's usually a metaphyseal defect, a void. You need to fill that, typically with bone graft, allograft, or substitutes. This supports your articular reduction, stops it collapsing later, underpinning the roof, like you said.
Right, structural support.
And finally, step 4. Fix the articular block to the shaft. Once the joint surface is rebuilt and supported, you bridge that stable block to the tibial diaphysis with plates, usually an anterolateral plate, sometimes a medial one too, depending on the pattern. That provides the final stability for rehab.
That's a very clear sequence. Fibula, joint surface, graft, then link to shaft. But getting access, surgical approaches must be critical, especially with those soft tissue worries. What's the main approach, and what combinations are definite no-nos?
Huge point. Approach choice hinges on the CT, particularly the axial cuts they show where the main fragments are displaced. But generally, the anteromedial AM approach is the workhorse, because often the fracture opens medially, giving you great access to the main articular pieces like chaput and the die punch. You can often see most of what you need to fix from there.
Okay.
And remember, if there's a big posterior malleolar fragment, you often need to fix that first, usually through a separate posteromedial or posterolateral approach. Use it as your keystone, build forwards from there. The AM incision itself is versatile too. You can work slightly more anterior or swing a bit more anterolateral under the skin flap to place an AL plate.
Got it. Now, the dangerous combinations. The ones to avoid.
Right, this is vital. Skin bridge necrosis is a disaster. So some combinations are basically contraindicated. A direct lateral approach is rarely used anyway, but combining it with a PL or AL approach. Very risky for the skin between them. You often can't reach key posterior fragments either.
Okay, avoid direct lateral combos.
And similarly, a direct medial approach isn't common, and combining it with a PM or AM incision creates a really narrow, precarious skin bridge. High risk of wound breakdown, infection. Just bad news. You have to plan your incisions carefully to preserve those bridges. Minimum 7 centimeters is the rule of thumb, but even then, be cautious.
That's a critical warning. Really emphasizes planning. Could you maybe walk through a couple of typical cases like a Ruedi-Allgauer type 3 versus a type 2? Bring it all together.
Sure. Let's take the type 3 Ruedi-Allgauer, the comminuted one. This often needs multiple approaches. You might start posterolaterally, PL, fix the fibula if doing it, and crucially, get that posterior malleolar fragment reduced and fixed with the buttress plate. That's your stable base.
Okay, posterior first.
Then you'd likely make your anteromedial AM incision, open the book, meticulously reduce all those articular fragments against the posterior piece you already fixed, address the die punch, graft the defect, then close the book and apply your anterolateral AL plate. For really bad type 3s, you might even add a minimally invasive medial plate for extra support, especially if the medial column is smashed. It's a complex, staged reconstruction.
Definitely sounds like it. And a type 2, the simple displaced one.
A bit more straightforward, but precision is still key. Often, a PL approach again for the fibula, if needed. Then an AM approach. Open the book, reduce that single main articular split anatomically, and apply your AL plate.
Seems simpler, but but still need accuracy.
Absolutely. Even a small step off in a type 2 can lead to bad arthritis later. So the principles are the same: anatomical reduction, stable fixation, just maybe fewer pieces to juggle. The strategy is always about systematically tackling the fragments based on the pattern, always aiming for that perfect joint surface.
So wrapping this up, what does this all mean for you? Listening in, prepping for exams, starting your career.
Hmm.
We've really tried to unpack the layers of distal tibia and pilon fractures, from understanding how they break, those key fragments,
Yeah, the Volkmans, the Chaput.
to the classifications, that whole fibula debate, and the step-by-step ORIF plan, including those crucial approach choices.
Hmm.
Getting a handle on these patterns and principles is massive, not just for exams, but for managing these really tough injuries well.
And maybe a final thought question for you to ponder, something examiners love. How do those other factors, patient comorbidities, PPD, diabetes, the state of the soft tissues you see acutely, how do they influence your decision between ORIF, or maybe ring fixation, or even fusion? Even if the fracture looks like a classic ORIF candidate on the CT, how do biology and the soft tissue envelope change your plan? Thinking through that justification, that's key.
Excellent point. Well, thank you for joining us on this deep dive. We really hope it's given you some valuable practical takeaways for your exams and your practice. And just one last reminder, all the detailed insights we covered are drawn from those Ortho Made Simple notes, which you can find at mokyingren.sg. Great resource to revisit. And as you keep pushing forward, studying, preparing for these big milestones, we just wanted to share a word of encouragement. It's from Proverbs chapter 11, verse 6. The righteousness of the upright delivers them, but the treacherous are taken captive by their lust. May you be blessed with clarity in your studies, diligence in your work, and success in all you set out to do.